So welcome to all of you. My name is Matthew Roderick. I'm the Executive Director at Unite Paralysis, and we are happy to host this event along with the ABT Association, ANABP. And I just wanted to start out by letting you know, first off, that Unite Paralysis has really long been interested in helping to support and strengthen the ABT sector. I'll tell you, as a person with a son with a spinal cord injury, my son was injured 16 years ago. 2 weeks after we left the hospital, the rehab hospital, we went to an ABT center, and subsequently over the next couple of years continued to do so. And since that time, in my role at U2FP, I've been in a lot of ABT centers, and I've connected with a lot of folks and really see the value that those centers and the work that you all do has on our community. Secondly, not to be crass, but let's be honest, if there was a cure for spinal cord injury tomorrow, magically, we're not ready to capitalize it in our community with spinal cord injury. We don't have enough capacity in rehab centers and even in the ABT centers to utilize it. And so that has to change. And that's one thing that why we're very supportive as we pursue our mission to accelerate curative therapies for spinal cord injury. Part of that is recognizing the capacity that's necessary to make the most of curative interventions for our community. And so this is why we've been involved in trying to connect and collaborate with and ultimately help to form this newly formed association of ABT centers. And part of that is also to reflect what you'll hear today from Christel and Sakina and Katie from ANEUVO, is that one of the areas that we see real opportunity is in utilizing activity-based therapy centers, freestanding centers around the country and Canada, as collaborators in human clinical research and even clinical trials like you will hear about today. And that's something we wanted to highlight, and that's one of the reasons why we wanted to have this webinar today. So again, I just wanted to mention, make sure that you keep yourself on mute as we go through the presentations. And if you don't, I will mute you. I hate to be rude, but I will just do that. Now, before we go further, I'd like to introduce Christel Mitrovich, who's going to talk first from Reneu Health in Southern California. Christel, also full disclosure, is a board member at Unite Paralysis, so I know Christel well. Please welcome Christel, and she's going to talk to you about Reneu.
Hi, everyone. Hey, Matthew, real quick. I just heard from Sakina. She's trying to log in, so if you could reach out to her, she's ready to go.
Okay, I will.
All right, let me share my screen, everyone. All right, hello, everyone. Good to see you all here. We appreciate you taking the time to join us. As Matthew said, my name is Christel Mitrovich, and I am a proud ABT professional. I've been asked to share with you today my experiences as an ABT professional and being a part of an ABT center, as well as our experience utilizing TSS in our practice. I'll talk a little bit about why we are excited about this technology, and now we are working to help bring it to market. Please move. Okay. All right, a little bit about me, very briefly about me. I know it looks like a lot, but we'll get through it quickly. I spent my whole career as an ABT practitioner. I started right out of grad school at a little place called Project Walk, where I fell in love with ABT immediately. I spent just over 6 years there before I moved on to another fledgling organization called Next Step Fitness, which most of you know as Next Step. There, I spent just over 5 years helping to build the program, its clientele, and its brand. And then in 2014, I joined Reneu Health, where I spend my energy and focus on business development, strategic partnerships, and as always, working one-on-one with my clients. As part of Next Step, I spent 5 years in the Neuro Recovery Network, where my co-speaker, Sakina, and I both helped to launch the first cohorts of the community fitness and wellness centers. We had a lot of fun together, sharing those experiences. I'm currently a board member of both U2FP and the Association for Neuroactivity-Based Professionals, where I work to shed light on the importance of and the necessary role ABT centers play in the continuum of care and advancing neuroscience research. I'm currently Director of Operations for Reneu Health and presently a site PI for the Aspire clinical trial for ANEUVO. All right, so here's a little bit about Reneu Health. In a nutshell, we are a team of mobile and in-clinic ABT practitioners. We're made up of lead kinesiologists and assistant kinesiologists, as well as mobile kinesiologists and assistants who travel to our clients' homes to provide ABT. We also have a clinical trial team of OTs, PTs, and a study coordinator. So like many of you, we cater to a wide variety of conditions, diagnoses, and physical presentations. We work with everything from stroke, MS, spinal cord injury, to the aging population. We really work in all mobility, but neuro is our main focus. Most of our services are mobile and provided in-home, as we cover Los Angeles, Orange, and San Diego counties, with our brick and mortar headquarters in San Diego. All right, the good stuff. Okay, so this is a big slide, so bear with me. So we have several directives here at Reneu Health. First and foremost, like all of you, we aim to strengthen the continuum of care for the neurologically injured and ill. Our goal for every client is to target activity-dependent neuroplasticity and neuroprotection. Next, we seek to lend our know-how and expertise in ABT to advance the field of neuroscience. We currently do this by supporting both exploratory research and clinical trials. We realized early on that our knowledge and skill set was unique and that we could play a very important and vital role in neuroscience, helping to advance knowledge and bring new tech to market. And then here are some examples of our partnerships that we have in the past and currently. So we worked with UCLA at both the Edgerton and Lou labs, where we provided in-lab activity-based therapy support. Our team would go there and provide everything from mat work, overground work, locomotor training, and community integration. We currently partner with Dr. Reggie Edgerton at Rancho Research Institute, providing ABT through locomotor training. Again, our team goes to his lab and provides the locomotor training there on site. We supported Spinex in its upper extremity clinical trial, providing in-clinic and in-home ABT treatment to study participants. We also assisted Spinex in exploratory research for cerebral palsy and lower extremity function in spinal cord injury. And we currently work with ANEUVO as a clinical trial site for their Aspire trial. We also work with Dr. Samadani and her team out of Minnesota at the Neurotrauma Research Lab, providing feedback and information on her Southern California epidural stim patients. We're a part of a cooperative group who provides similar feedback. We provide real-time updates on the best ABT, neuromodulation practices, and stim parameters. And we have recently partnered with San Diego State University to begin some of our own exploratory research in Parkinson's. All right, thanks for staying along. This is another big slide. So TSS is a very high priority initiative for us, and I'm going to talk a little bit about why that is and why we're excited about this technology. First and foremost, I'll start at the bottom. The biggest reason we're excited about this tech is because we've seen improved motor learning and motor output in our clients and study participants. We've seen improved postural alignment, which is something we're always striving for when working with our clientele and study participants. We've seen improved proprioception, which leads to higher quality motor output and increased motor learning. And we've seen increased endurance. So our clients and participants are producing stronger output, more reps, and longer bouts. Okay, next, logistically, it's easy to use. TSS is fully integrative. We can use it in mat work, we can use it in our overground work, in our body weight support treadmill system, exoskeletons, standing frames, etc. I love it because it's mobile and compact, super lightweight. I can put it on my client and we can keep it on them the entire session as we transition from one modality to the next. I can put it in my backpack and get in my car and bring it in home and use it with my clients there. And it's easy to apply. I know it, I'm probably oversimplifying it, but it is easy to apply. You put the electrodes on and you get to modulating. It's customizable. Now, every device is different, but each device can be customized to fit each person's tolerance level, their condition or diagnosis or injury. It can be customized to meet each activity. So if we're doing something a little less intensive, we can modulate the stim to meet that effort level. And then conversely, we can increase stim to match a more higher effort activity. And I'd like to point out that ANEUVO is one of the best devices we've used, in that it allows for more customizable programming. It's much more flexible. It allows us to meet every client's tolerance level, which allows for more optimal neuromodulation. We can target bilateral, unilateral, we can target proximal and distal. So again, these are new techs that we're very excited about, and we're super proud to be helping to bring this to market. And then through our exploratory research, we've seen that TSS has a wide variety of use cases outside of spinal cord injury even. We've seen benefits for Parkinson's disease, cerebral palsy, and stroke. And we believe there's more use cases out there to be developed. And Matthew, do I have a little bit of time?
Yeah, you got a minute or two, sure.
All right, so these are just some visuals, some pictures, some videos of just how we've integrated TSS into both in clinic and in lab and even in home. So you can see here, the hardest setup here is actually getting the client into this rift in here. The TSS is fully integrated into this. It allows us to do overground walking in a rift in. Again, the most complicated part is getting the patient client into the rift in. TSS is fully integrated. The middle example here is in lab, experimenting with exoskeletons here. This is a hip extension exoskeleton. Again, TSS fully integrated. We went from the mat to the exoskeleton, very easy to integrate, easy to apply. And then last is a body weight support treadmill system. Again, just kind of highlights, and even the most complicated modalities, interventions, that TSS can go right along. And I have one more. It'll let me, all right. And then here's this video. It's actually, we're outside, walking with it outside. You can see the practitioner behind the patient. He's got it on his pocket. And now we're outside practicing community integration. And then the picture to the left is an in-home client practicing some dexterity and finger exercises. All right, there's one more slide, but really there. Okay, so that's it for me. I put my email up there. If there's any questions you have for me, please feel free to reach out to me. This is our website and the association's website, as well as U2FP. I appreciate your time and attention. And with that, I'll pass it on.
Thanks, Christel. And again, remember to stay on mute. If you have questions, put it in the chat. But first, we're going to go to Sakina. Sakina is going to share also with you regarding Triability, which is in Chicago, another center that is partnered with ANEUVO and others as a collaborator. Sakina, you should
Hi,
be able to see your
everybody.
screen. And
Yeah.
once Sakina's done, once Sakina's done, then we'll open it up for questions for both Sakina and Christel. Go ahead,
Yeah,
Sakina.
sorry about that, and I apologize. Had some issues today with traffic getting in, and also I'm having some connectivity issues with my laptop, so I'm speaking from my phone. I apologize. So my slides are difficult to share. I'm trying to send that over, and I really apologize for some of these issues. I didn't anticipate them, but from my perspective, I can send those slides as prepared them after I'm done speaking in the background to share with the group. But just
Sakina,
a little back.
excuse me. If you'd like to send them to me, I could share them for you if you'd like.
Absolutely. I've been trying to do that actually via my computer.
Okay.
And it's just not, I'm sorry. I don't know if it's just one of those days that I'm having just all kinds of issues with my laptop, trying to connect at home to send you guys over. I keep on getting kicked. So I apologize for that. But I will definitely share it as soon as I'm done and I can actually focus on trying to do this. I apologize. One of the, just introduction wise, I'm Sakina. I'm one of a physical therapists that I've been kind of working with the ANEUVO in the clinical trial, the Spinal clinical trial. We got involved a year ago and have now about 10 to 11 patients that have been enrolled in the clinical trial. One of the biggest things, as we all kind of understand, also Christel alluded to, transspinal stimulation really helps kind of activate motor, kind of drive motor output by activating sensory pathways, and it kind of works in a really good, robust manner to generate motor output. ANEUVO in itself, based on some of the clinical devices that we've used, as Becca from Kennedy Krieger had kind of spoken on it at one of the Working to Walk conferences. Clinically, there's been applicable for the past 4 to 5 years, in which we're using just devices that are available on the market to kind of help use this technology to kind of drive motor return. But with ANEUVO, what we've really seen is because of the specific kind of parameters, multi-channel electrode array that kind of goes on the skin, you can really customize it to based on the return that you're trying to look for. In the case of this trial, it's mostly looked at upper extremity return of function, right? So in the clinical trial, we've been focusing on really looking at upper extremity motor scores and have not necessarily studied or looked at return of motor function below the upper extremities. But what we have seen is that individuals in concomitant with the aggressive therapy in the protocol, patients who are in the active group are getting really good motor return. And these are injuries, patients with injuries with complete injuries as well as incomplete injuries, correct? So it is really exciting to see this. There are some conundrums and some issues in regards to really customizing it to the protocol based on patients' tolerance and stuff like that. And we've had to kind of work with patients to really build tolerance to the stim, because it is not painless, but it's a lot more tolerable than the ones that are available on market in regards to the sensation of stim. And the user interface is very similar to some of the devices that we have seen on the market with the restorative therapies, in which you can kind of turn on and off programs and kind of test or muscle test different muscle groups to get the response that we kind of need. From our perspective, I think from a therapist perspective, to see this technology be so easily available and applicable to patients to really kind of see what their potential is for recovery without having to go down the route of invasive epidural spinal stimulation surgeries or anything like that, to just really see what their potential is for motor return has been really exciting. And a lot of the patients that we are kind of seeing have really reported that they feel like, just like Christel said, not only is the power or the strength in response to those movements have improved, but the endurance aspect of it. And as we know, our patients not only struggle with motor fatigue, they also kind of struggle with this global fatigue with the amount of effort they put into doing a task, right? Just the task of reaching for an object takes a lot of planning, it takes a lot of compensation. But by having transspinal stimulation on their body helps them kind of get that extra drive to make that task more efficient, and their energy expenditure goes down. And because of that, they're able to do the task longer. And a lot of patients have reported that during the clinical trial when they're kind of talking about their experience with the device. So from our perspective, I think it's a really exciting technology that's available. And I think we've just scratched the surface of what the potential is. And we're excited to see its application be widened in regards to lower extremity return. And from that perspective, from the clinical trial, obviously we're limited to kind of really looking at motor outcomes in regards to upper extremity return. But just even in the fact that individuals have the ability to put this on, a caregiver can be trained in regards to, once the programs have been set for the patient, it's not like you're constantly making changes. It remembers everything that you were set the last parameters to. So if a caregiver were to have this on them, or a patient were to use them on themselves in the future when it's available, I think it would be totally doable. Some issues that we've had are been in regards to connectivity of the electrodes with the skin. And we've had to use some other forms of like taping to kind of keep the electrode on the skin, just to make sure there's no errors, or in regards to the clinical trial, because we have a certain amount of time to get the entire current through the patient. But a lot of that, I feel like we had a lot of support from the ANEUVO team and the entire clinical, as well as the engineering team, to help troubleshoot these issues and come up with solutions to help make the whole experience for the patient as well as the therapist kind of enjoyable and make it more user friendly. I think, you know, as far as the size of it, absolutely, it is totally transferable, transportable in a backpack. You know, the user interface is something that I can see therapists who are not trained in FES or advanced FES technology need some continued ongoing training, because it can be a little daunting. But for therapists who are comfortable with FES technology and are aware of the new tech that is available, it is very user-friendly from that perspective. You know, and I apologize, I guess, sorry that I don't have that many slides at this point to share, but I will share what I had post the presentation, so you guys can kind of see what our patients and what things that we've been tracking with as well.
Thanks, Sakina. Well, let's open it up for questions to both Christel and Sakina. I see there's already a question in the chat from Rebecca Wheeler. How do you determine where to place the stimulation pads? Yeah, so I can answer that first, and then Christel, feel free to chime in. So, you know, with the ANEUVO pad, there's one active electrode, which is an array of 16 small electrodes on a big electrode pad. And there is a guidance of placement. It's right on the cervical spine. You have to make sure that it's obviously not touching C1 or C2. It's a large electrode. It's about, I have to say, at least 6 by 6 inches, like a big one with 16 array electrodes. And then we want to make sure that the bottom part doesn't pass T1. So it kind of covers the entire back of the neck of the patient, depending on the length of the neck. And then there's 2 grounding electrodes, which are at the abdomen, and they are the ground and the inactive electrodes per se. So the current is being driven from the back of the neck, posterior of the body, to the anterior aspect, which is the abdomen, which is the ground electrodes. So a total of 3 electrodes are being applied on the person's body. Thanks, Sakina.
Yeah.
Yeah, and I don't have too much more to add to that than that. If there's cervical injury, you know, some of the other devices you can target, you know, you put the electrodes, the lead electrodes at the cervical level, and then you can put thoracic and lumbar, depending on how they present and what area you're trying to target. And everything's protocol based. So there wouldn't be a lot of guesswork, I think, at the point when it came to market, that all the protocols would already be laid out.
Thanks, Christel. Anita, you had your hand raised. You'll have to unmute yourself.
Yeah, can you guys hear me?
Yes.
Okay. So I just want to get a clarifying question to your response, and then I'll ask my question. So if you put in the cervical spine, that's specifically to target upper extremities. If you put it down in the lower back, that's to target legs, correct?
That's correct.
Okay.
But the data right now, what it talks about is that the application of the electrode on the cervical spine actually has effects on the lower extremity as well in modulating of the H reflex activation. So a lot of stuff that we are looking at clinically right now looks at multiple points of activation of stim electrode pads being applied at the cervical and thoracic spine. The ANEUVO currently is only at the cervical spine and is looking at activation of upper extremity muscles. My understanding and hope is that in the future, when it is available clinically, we will see a lot more carryover of some of these results that we're seeing because patients, obviously, it is not really isolated. When you stimulate one part of the spine, there is a modulation effect above and below the level of injury. So at this point, the ANEUVO device is looked at application on the neck to modulate upper extremity responses. And the thoracolumbar placement is more directly looking at modulation of locomotion. But in the future, I foresee multiple levels of stimulation because the cervical spine definitely modulates activity lower in the lower extremities as well.
Okay, so you kind of just already answered my other question. I was going to say, can you actually place it on two areas of the spine at the same time while someone is working to activate both upper and lower? But right now you said not really, although if it's on the cervical, it could potentially target everywhere. But at this time, it's really sort of pick a location and go with it to target the main one. So the other part I wanted to ask was, have you combined FES with TSS?
Yes, we have clinically, not in the clinical trial, but the clinical trial does not allow of concomitant use of concurrent use of FES along with TSS during the clinical trial, but patients can use it outside of the clinical trial. Having that said, clinically, when we are using non-ANEUVO based devices for TSS, we can pair TSS with NMES or regular FES devices if we notice an area of, disuse atrophy where the muscles need to be reconditioned. You can definitely do that. We just have to kind of base it on what the goals are. Correct? If you're really looking to get a motor response and really understand what modulation of the spinal cord can do in regards to movement, then it's not advisable to use FES at the same time because you're kind of sending confusing messages to the spinal column because of the different modes of activation. And also you're going to create more fatigue within the muscle. But if your goal is to really recondition the muscle, strengthen the muscle, not looking at locomotion or motor output necessarily as far as volitional movement, you can pair them because you are just using TSS to increase spinal cord excitability at that point.
Okay, thank you.
Question from Melanie Brennan. Are you seeing other improvements such as bowel bladder and sensation to either of you?
I think, again, in the clinical trial, we're not really tracking those markers yet. I think the goals are around return of upper extremity function, mostly motor scores, and there's some other like postural control and other forms of outcome measures that are looked at as secondary. Bowel and bladder, in my understanding, is not necessarily that is being tracked at this point. But I do foresee it being an area that could get better with continued use.
Yeah, and I can say that in lab and some of
Go ahead. Sorry, Christel.
Sorry, in lab and some of the exploratory research, yes, we have seen improvement in bowel, bladder, sexual function, and sensation, but very, very limited data at this point.
I wanted to ask, since I know both of you, this takes it outside of TS, but both of you are seeing clients with ES, epidural stimulators. Are you seeing any evidence of that in some of your clients?
So epidural for bowel and bladder, Matthew? Yeah, so definitely yes. So one of the things with epidural stimulation we are seeing is a lot more consistent reports of improvement in bowel and bladder, even more than consistent report of stepping or walking per se. So, I think it becomes in the end what the patient or the person or the recipient ends up using it more for, right? Everybody at this point who are acquiring epidural stimulation outside of clinical trials have the freedom to kind of just use it for how they like it outside of therapy hours. And what we have noticed that individuals who have identified programs that help with bowel stimulation end up using it more. I've had individuals now be completely rid of bowel programs and being able to evacuate on their own. And some individuals are now even being able to evacuate without the stimulator independently after using it after a certain amount of time. And those individuals are also now being able to move their lower extremities without stimulator response. So, obviously the body evolves and adapts to continued stimulation.
Mhm.
And I'll say the same thing that, the patients we see from Dr. Samadani, they have it for various reasons. And so the reason they see us is really to target motor outcomes and motor output. But I know that there's, I think Laura's on. So if she wants to comment on bowel bladder outcomes, then I'll let her do that. But we don't really track that in those patients.
And just to clarify, so for those of you who may not know, those patients that are being seen clinically are actually given preset parameters that have shown or hypothesized to function for cardiovascular function or bladder or movement, etc. And so when Sakina was talking about what people choose to use, it's folks choosing to use certain stimulation parameters that lend themselves to those various functions and have by the person's choice. I'm going to read one more question and then I'm going to hand it over to Katie and Katie. From who is this? Helene, have you seen improvements? Are these in complete injuries, assuming Asia A injuries or Asia B motor complete?
So from our perspective, transspinal stimulation, and I'm assuming the question is about transspinal stimulation. So with the ANEUVO trial, we have seen improvements in complete injuries as well. And these are cervical complete injury patients, and they're all in the chronic phases. So they're at least a year out from their injuries. So the time since injury in regards to chronicity doesn't matter. Yes, we have seen upper extremity motor return in individuals with clinically diagnosed motor complete injuries, which are Asia A and Asia B.
And I'll just speak to what we've seen in other trials. Yes, we've seen improvement in motor outcomes and motor function improvement in complete injuries as well as incomplete. So yeah, but again, very, very limited data on that.
Okay. Thanks, Christel. Thanks, Sakina. Now I'd like to hand it over to Katie Velez from ANEUVO. Welcome, Katie, and Katie Bartholomew as well.
Hey, everyone.
Hi.
I think I'm going to get us started and then I'll pass it off to Katie Velez, but we our double Katie's make it very easy for you to remember us. So I am Katie Bartholomew. I am the clinical field specialist with ANEUVO, and I am an occupational therapist by background. So up until about 6 months ago, I was a full-time treating clinician in an outpatient neuro rehab setting, and joined ANEUVO and have been a part of their clinical team. So we thank you for inviting us to this today. This is all really exciting stuff to talk through and really see how we can continue these types of partnerships moving forward. So Sakina and Christel did a really wonderful job highlighting a lot of this stuff, but this was really the basis of developing our TSS system, in that there's a lot of really great early data to support improvements in individuals' voluntary motor control, specifically upper extremity grip strength and function, We're seeing an improvement in postural stability and bowel bladder function, as well as sexual function, thermoregulation, and cardiovascular functioning. We're seeing a reduction in spasticity and an increase in sensation, as well as an ability to see that we are truly exciting these corticospinal pathways to stimulate those dormant pathways within the spinal cord to promote or enhance this voluntary movement. I'm sure you're all incredibly aware of the SCI standard of care, but I highlight discussion today because I think this is really where ABT centers and individuals like us trying to launch these investigational devices really come together. Because we know that there is no cure for SCI as it stands today, and we're all well aware of those acute and subacute stages of care. But once we really hit that 3-month post-injury, many individuals are met with this theory that they're going to plateau. And there really are very limited treatments out there for them to pursue. So that's why I surely love ABT centers and that they've become much more accessible to individuals in the community, in that you are looking at the continuum of care far past this 1-year plateau. And that's what us at ANEUVO are trying to accomplish as well, right? So we're looking at what happens to these individuals in the chronic stages of their recovery, and how can we continue to support their recovery, and not just kind of give them the traditional answer of you've plateaued, or you need to go for more compensatory strategies, and we don't see a need for any further remediation techniques. And you guys at ABT centers are really kind of blowing the lid off of that theory. So just as a clinician, I'm incredibly grateful. But again, it does set up, for us looking at these partnerships and ways to get this product into more people's hands. We really see the value in the community outreach that you bring. And again, just the like-mindedness of trying to support continued recovery far beyond what the standards of care are today. So just to quickly introduce what the Exosim is. So it is that non-invasive transcutaneous spinal stimulation. It is made up of this generator right here. And then this is our 16-channel multi-electrode array that is applied to the back of the neck. This is kind of just a nice visual of how it all works. But you are able to independently program each of those 16 channels on that electrode. Each of them is able to be programmed individually with different amplitudes, pulse width, and frequency. So it's highly customizable. And what that allows us to do is create this spatial motor mapping, so that we can recruit as many or as little and target different muscle groups to promote this improved sensory motor voluntary movement experience. And again, by highlighting some of those, or again, by creating some excitability to those pathways in the spinal cord. Just to share a little bit before I pass it off to Katie. So we did complete an upper limb pilot study ahead of launching this clinical trial. And I just would love to share a couple really great videos here with you. So these will play simultaneously, which I think that alone speaks for itself. You'll see the blatant difference, but I'll talk you through just the difference in this individual's speed of movement, their motor planning, their ability to kind of their distal mobility skills in general, and then just the ability to initiate multiple muscle groups at one time to create a full functioning movement pattern. So I think this is a nice highlight of just where this person, after receiving the treatment, where they've been able to benefit in terms of their upper extremity functioning. This one here, so you'll see the first video is highlights this individual who had 8 weeks of standard rehab care with what we call sham stimulation, followed by 2 weeks of rehab with the active stimulation. So you'll just be able to see here the difference, even though it was only 2 weeks of therapy, additional therapy that they got versus that initial 8 weeks. Again, the ability to motor plan and initiate their movement more smoothly, and then again, just actually execute a stronger grasp pattern. And our last one here, this is just completely before any type of TSS training, again, followed by that after. So you'll see much more improved initiation of grasp, as well as the grip strength, ability to maintain that grip while they are pronating to turn that bottle to pour. And that is where I'll end kind of some of my intro here, and I'll pass it along to Katie to kind of share a little bit more about how we teamed up with ABT centers when we got our trial started.
Thanks, Katie. Just by way of introduction, I'm Katie Velez. I'm our VP of Global Marketing at ANEUVO, and I've been in neuromodulation for a little over 20 years throughout my career, and with ANEUVO for 3. And this has been a really exciting time getting to develop a therapy really from bench through the preliminary translational research and into large randomized controlled human trials. And so it's been an evolution that can only be done with partners such as yourselves in the ABT space, as well as academic research and clinical centers. And so one of the things that I wanted to sort of focus on, at least during my time, is how do we select clinical partners to conduct large RCTs with? And I think in the ASPIRE trial for us, which is a 140 patient, 14 center, randomized controlled double-blinded study that we're in the process of finalizing, we really wanted to recruit a mix of potential future customers, right? So we've got a really good mix of large academic research institutions. We've got a mix of labs that really are focused on research and clinical care that aren't affiliated with academics. And then the activity-based therapy centers like Reneu and Triability, where you folks are really seeing these chronic patients on a day-to-day basis for their outpatient clinical care with varying durations, right, of presentation and their symptomology and the disease state and the chronicity and the severity of the disorder. And I think that by having engaged sort of the different segments, right, of research partners, what we're finding, is that we're really getting solid feedback and insight into how this will be used translationally once we do come to market with our system and device. And I think that one of the conversations that Matt Roderick and I had with some ABT folks previously was, how do I get engaged in studies like ANEUVO is sponsoring? And I think one of the most important things that we look for is, do you have a dedicated team of professionals that can really adhere to good clinical practice and a solid protocol, right, adherence? We do 8 weeks of active active therapy combined with either active stimulation or sham stimulation. And that's 3 times a week for an hour to an hour and a half a session, right? So it is a time commitment for your staff, right, and your interventionists to be able to block time away from their clinical calendar to accommodate these patients coming in at that frequency. And then also, what sort of support do you have from a coordinator perspective, right? Do you have people that understand how to guard data and enter it into electronic data capture systems and follow the case report forms and all of the sort of infrastructure that's involved in conducting a formal clinical study? And then for us, like with Aspire, we look specifically for licensed therapists, right? So that there was a little bit more consistency and inter-rater reliability and in the ability to perform the assessments that we do conduct for our primary and secondary endpoints. And so as we looked at branching outside of your traditional research centers, we really wanted to find teams that had solid sort of pipelines of the patients that we were looking for, as well as the ability to support a longer term, more formal study. And I know, Matt, that you said that we're running out of time here, so I can open it up for us on our side for questions that you may have for Katie and myself.
Thanks, Katie. Yes, please. So I see one question from Heather Karen Mills. What would the price point of Unit B when it is launched? Will it be affordable for smaller clinics?
That's a great question. And while I can't specifically tell you our pricing strategy for go-to-market, I think it's really important to say that we are focused on making this affordable and accessible to both clinics and patients, because we do plan to launch both in hospital, in clinic, and at home. And so if we compare it to your like traditional FES bike, we're going to be substantially, I think, more affordable in terms of the capital equipment. But we do have the electrode pad, which is a consumable, disposable electrode. And so there will be an ongoing carrying cost for both the clinics and the patients to support continued use of the system once purchased. With that being said, we've already outlined a robust market access and reimbursement strategy where we will seek to get the highest reimbursement coverage for people in order to be able to access the system.
Thanks. From Melanie Brennan, you're wrapping up this study. Are you looking for centers for a next iteration study?
I do think we will be doing that. Stroke is an indication that we are interested in pursuing clinical research around. We have had discussions around conducting additional research for indication expansion within the spinal cord injury population into non-traumatic spinal cord injury, as well as subacute. And while we did already complete a small single center pilot study on lower limb, I think that there's appetite to look at our X-System system in a lower limb ambulation as well on a little bit of a broader scale. And so I will also like go back to talk about the bowel bladder question around TSS. So right now in our study, we restrict the sites to cervical placement, right? Because we are very highly focused on evaluating what kind of motor improvement and restoration that we can get for upper limb paralysis. With that being said, I think that a lot of the research that's already been conducted indicates that a thoracic placement is probably more appropriate for bowel bladder management. And so anything that folks are seeing through the trial or previous trials anecdotally out of the cervical, I think only has the greater potential to like really demonstrate improvement once you have lower extremity or thoracic placement of the electrode pad.
I have a question for all 4 of you. Back to this sort of overarching frame that I started the webinar with. what are the, and open to any of you, what are the real opportunities in utilizing ABT Center for clinical trials like this? And what are the pain points that might be different than if you were in a traditional healthcare setting or an academic setting? What are the what's the, like, you know, the good and bad of this scenario?
I'm happy to start first, if that's okay. Being a physical therapist and being having worked in the hospital systems and now being a part of a private ABT center, I think the biggest thing is the lack of red tape. Correct. So I mean, I think it is much easier for our staff that is very equally highly trained in application of these principles and or interventions to conduct these clinical trials without some of the other organizational limitations that can happen with the execution of these trials, correct? The second piece, I feel like our patients is a lot more, we have a lot more, I think, loyalty and access in regards to getting patients to commit to clinical trials, because it is a very daunting process. There's commute times, there is keeping appointments within a certain amount of time, being able to alter our schedules to fit the clinical trial appointments within the 7-day window. I think smaller centers have more, I think we're more motivated, as well as have the capability to make these adjustments to meet the requirements of the clinical trial. You know, so these are some of the advantages I feel will help push the science forward to get the amount of patients that are needed and the numbers that are needed to get these devices approved, right? So this not takes years and years. The downside to it is a little bit because our resources are limited. We have to kind of look at managing these, the other, like the paperwork, the coordination of the clinical trial. That can be a little bit more painstaking in regards to being a smaller clinic, because we don't have established individuals who help us run these clinical trials. So it has been a learning process for us. But I have to say, ANEUVO's team has been very patient, and also Proxima, that is the clinical trial execution team that ANEUVO has worked with, to kind of help us sift through the paperwork and make sure everything is deemed correctly with the FDA guidelines.
Yeah, I'll continue on with that. I think one of the biggest hurdles for us as I would say, more traditional ABT center, in that we have kinesiologists and exercise physiologists on staff, is that we needed to hire on a dedicated clinical team. So we needed to make that financial commitment to bringing on the PTs, OTs, and study coordinator that we had been working with through collaborations previous to that. So that was a hurdle. But I would say, in terms of ABT and some of the opportunities that are available right now, I think exploratory research is a big one, that if ABT centers have the capability of being mobile and going into lab settings to provide any kind of ABT support, that's a big opportunity that's out there. I think our ability to provide feedback based on what it's like to administer therapy or treatment in home is very, very big, because I think that's where a lot of these treatments are going, and will have the most impact. And so just as an ABT center, we have a lot to give. And I think, you know, there are opportunities to be had and taken advantage of right now. And then I think with a little bit of creativity, you know, there may be options to have, you know, these bigger institutions and an ABT hybrid type thing, where again, we can really help with the recruitment and the what's the word I'm looking for, compliance of each study. So yeah, I mean, that's kind of my 2 cents there when it comes to opportunities for ABT centers.
Katie or Katie, any comment?
I would echo what Sakina and Christel have said. Bureaucracy is not nearly as much of an issue when you're talking about working and partnering with an ABT center versus a large academic institution, all the way along the pathway from your institutional review board through getting contracts inked and signed, right? That's I think a lot more fluid process. I think that the only pain point that I've really seen both at ANEUVO and just in general, with working with non sort of traditional research or academic research centers, is staff turnover and staff availability, right? So when you have someone who is assigned to a clinical study but is also doing clinical care, and there's any wax and wane in the recruitment or the enrollment of patient schedule, oftentimes those people can't be just held, sort of kept on to support the research, because they have to be reassigned back into clinical care, or usually that's typically what happens, right? But one could argue that in a large academic center, what you find then in terms of turnover and bandwidth is that they're running multiple competing studies, sometimes often even within the same patient population, right? And so then you're talking about sort of rationing one patient that may be a great candidate for this study to another one. And so there's always sort of trade-offs when you look at any type of research partnership. But I think we've been incredibly happy to have, again, diversified our mix of sites that we've partnered with, because each one brings sort of a different benefit.
Great, thanks. One more quick question from Core Florida. I'm not sure who, I know who Core Florida is, but not a name. Can you tell us at all, Katie or Katie, about the expected launch? What are you looking at from the FDA, next iteration of study, and specifically in spinal cord injury?
Yeah, so I'll say we hope to be on market in early 2026, right? We're actively pushing for completion of the Aspire trial, and then we're granted breakthrough device designation with FDA. So one of the things I will say about the Aspire trial is that we took 9 months prior to ever launching it to enter into a clinical protocol agreement with FDA, which essentially de-risks the fact that when we come to FDA with a marketing submission, that they'll say that they don't agree with our clinical trial design, or that, we face longer delays in the evaluation of the study because it didn't meet the criteria that they were looking for, as far as, randomization, blinding, so again, we hope to be on very early 2026 in the US, potentially in other places sooner than that. And as far as other research, we are constantly going to be generating evidence, right? It's really important to have evidence generation to support not only changing the indication and for use for the therapy, but also making sure that we have the strongest body of evidence to go to, Center for Medicaid Services and private payers with, to support getting the highest coverage possible for this, so that it is affordable and accessible. So
great. Thanks, Katie. And thanks to all 4 of you. I appreciate the presentation. I'd like to give a few minutes to Cynthia Templeton to talk a little bit about the Association of Neuroactivity-Based Professionals, which is bringing you this webinar alongside U2FP. Cynthia.
Great. Thank you, Matthew. Thank you, everybody, for being on the call today. This is really exciting and very informative to me as not a practitioner, but on the business side of the ABT centers. My son, so similar to Matthew's history in getting involved in the community, my son, Darren, sustained a spinal cord injury 20 years ago. And we live in New Jersey. We traveled back and forth to California 5 different times to go to Project Walk. Had the opportunity to work with some amazing trainers there in what was really the first ABT center in the country, and during the course of those trips realized that New Jersey needed a program like Project Walk, and so we formed Push to Walk in New Jersey, and we've been open almost 18 years now. So I'm coming at it from the business operations side of things, but have had the opportunity to work with amazing trainers and practitioners and professionals across the board in ABT, and which led me to work with a group of small group of very dedicated people to the cause of forming an association so that we can organize ourselves as centers and work together and share ideas. And the idea of being a connector of sorts to the researchers and the companies that are developing products and equipment. It's the ABT centers who have all the clients and the patients that you need for your studies. So it's the perfect synergy to really explore and get off the ground. And we've talked about developing like a clinical readiness scale so that we can help all of our centers be ready and be set up for these kinds of projects. So that is an important focus. As we more fully form the association, because it's been in, you know, the idea stage and our infancy for quite a long time, more than I care to really admit or acknowledge, but it is what it is. We all have day jobs that really take our priorities, and sometimes the association tasks fall down towards the bottom of the list, but we're all doing as much as we can to bring it all together. And there are several members of the association board and organization on this call, so I'm happy to see all of you. I think there are some really, you know, valuable opportunities for both the researchers and the companies and the ABT centers to work together. So hopefully projects like ANEUVO's and the Aspire trials will be just the beginning of the things that we can do as an association to bring those two different factions together. And the team that's working on the association brings a variety of education and knowledge to the group so that we have various perspectives. And Tommy Suter, who is on the call and is a former ABT trainer and program director at Push to Walk, left us to pursue his PhD in rehabilitation science and is now a postdoc researcher working on some exciting research. And he brings a perspective of sort of bridging both worlds, like knowing the ABT community from the practitioner professional standpoint and also being a researcher. So we are hoping to, you know, get the ABT centers to want to be members of the association. And then once we're just a little bit more fully formed with our memberships and being able to bridge the gap between the centers and the researchers. So Tommy and I are both available to answer any questions you may have about the association or provide any other information that you may want to have.
Thanks, Cynthia. Any questions from anyone?
I'm just, I don't have a question, but I just want to chime in real quick. I'm Tommy Suter, and I have my video off because there's a lab in the background of me where some participants are participating in research. So to keep their, protect their identities, I've got my video off. But yes, I can put my email in the chat. And like Cynthia said, I'm happy to answer any questions that anybody has about the association now or after the webinar.
Thanks, Tommy. Thanks, Melanie.
Thank you, Melanie. It's a, what do they call it? It's all about the passion for it and just continuing to carry on and get this up and running. So we're getting closer every day. We have a great group of people and look forward to being ready in the very near future to actually feel like we have value to offer to potential members, get them signed up to be members, and be a real part of the whole community and bringing everyone together.
Yeah, and I just want to reiterate what I said at the beginning. Unite to Fight Paralysis involvement goes all the way back to, I know Cynthia and Tricia will likely remember at a symposium that U2FP hosted in DC, was a shuttle ride that we took to Kennedy Krieger, where we had a conversation some, I don't know, 9-10 years ago about the need for this connector across the ABT sector. And all along, it's been a sort of needle in my mind to think about a few things. And one of them is to elevate practice. How can the centers collectively elevate what they do with our population and other populations, other CNS disorders that you see? How can we elevate business practice, share best practices? So many ABT centers struggle financially and is a challenge to stay in the black. How can we help that collectively? And then the thing that we're doing today, which is looking at the opportunity, I still feel it's such an untapped source across the ABT sector of connection to people with SCI, but also connection to escalating research practices, escalating clinical trials, moving things faster than they have been. And one of the other pieces that we've already embarked upon is kind of an early stage of the activity-based association or the ANABP is to look at, no one has ever done a rigorous large-scale research trial on understanding the public health impact of what you all do in the SCI population. We all know that it's of benefit, but no one has ever rigorously studied it beyond a small, like 6 people or 10 people. They've never done large numbers of people over time. And our belief is that if we can execute that, which we've done the first foundational study and ready to move on to the next, is to do a public health impact study that would show data that you could take to payers, that you could take to CMS and say, you know what? Exercise is medicine. Exercise does reduce some of the secondary complications that come with spinal cord injury. You should pay for this, at least in part pay for this. And so that takes the burden off the SCI population. It also takes the burden off your centers. And so all of these things are things that we think the association can fill in a lot of gaps, but it's a kind of crowdsourcing operation. So keep that in mind. So with that, I just want to say thank you for being here today. Thank you to our 4 presenters. Thank you to Cynthia for sharing about ANABP and Tommy. Please reach out. Tommy's put his email in the chat. You can grab that before we hang up. Reach out if you have any questions about the association. Reach out to me if you'd like. I could connect you with any of the folks that were presenting today, either at ANEUVO or Christel or Sakina, if you have further questions. And of course, we will, this is being recorded and we'll figure out a way to, post it on our website or to YouTube or somewhere. We'll let you know. So thanks for being here. I appreciate your participation, and thanks Katie and Sakina and Christel for sharing.
Thank you, Matthew.
Thank you, Matthew.
Thank you.
Bye all.
Bye, everybody.